My name is Stephen Rue. I am the medical director at Riverside Treatment Centers, as well as the medical director at Coastal Recovery Center in Wilmington. Um, I am a board certified anesthesiologist as well as a board certified addictionologist, and I've been in this field for probably close to 25 years.
When assessing patients, how do you choose or what's your process for choosing the best medication for each individual patient?
Bottom line for that is, what does the patient want? Um, Generally you will ask them. Most of them are going to come in because getting on methadone. Most of them are more familiar with that. Many of the folks that come to us have experience with buprenorphine, either through other treatment or through attempts on their own to obtain illicit buprenorphine and try to treat themselves. There are occasionally situations where, in the history we find out that they've been on buprenorphine before, and it really didn't help them that much, in which case we might steer them more toward methadone. If they're still coming in to get on buprenorphine, it's just like, well, you didn't do well the last time, so let's try something different.
In terms of getting patients balanced on medication, what approaches have you found to be the most effective?
The most effective is to be able to see them on a regular basis, either face to face, myself or the PA, or to have the counselors or nurses checking in with them on a weekly basis, seeing them on a regular basis, adjusting their dose until they tell us that they're comfortable. And the goal is any dose, whatever that might be, to block withdrawal, block cravings, and give them no excuse physiologically to be using anymore from morning until morning. That's the goal. There is no such thing as a high dose or a low dose. There is only a right dose and a wrong dose.
When treating fentanyl patients, what medication have you found to be the most successful in your experience?
For the most part, methadone is probably your better agent because there's no limit to the dose you can actually give them unless they start getting serious side effects from it. Buprenorphine is limited, particularly for the patients that are using a lot of fentanyl or have been using it for a long time, because it's just not dense. Once you reach its 28 milligram or so maximum dose, there's very little benefit you get going up. And if their tolerance level exceeds that, they're never going to be comfortable. At least with methadone, you can continue to increase the dose until they get stable.
How have you used the hub and spoke grant funds so far for this initiative on, balancing patients on the right medications and having a really patient-centered approach?
Since I came over to Riverside, we've had lots of patients who would otherwise not be able to get in treatment, who we've been able to get them in and begin to medicate them to a point where they're stable and sober. Also having the hub and spoke in Victoria, who can hunt around for places where we might need to refer people for additional care. So being able to refer them to a different residential type program or another one where they can have their co-occurring substance use disorder managed while they're continuing to work with us and receive their medication has been really helpful.
Absolutely. Love to hear that. Many patients.
Mm-hmm.
Victoria, at Riverside Comprehensive Treatment Center, you offer optimal patient care, as Dr. Rue has explained for us. Can you speak to how the attitudes and energies of your staff benefits your patients?
Our staff is very empathetic. They relay a very positive attitude toward helping our patients, such as what Dr. Rue was saying. We don't judge them. We don't put them under a finger per se, so that they feel uncomfortable. We give them a very comfortable welcome and let them know, hey, we're here to help you. Some of us have been through similar situations and can empathize with them, and just being able to explain to them, yeah, I know, I've done that before, this is what happened with me. We can set a positive plan in action that actually helps them, and this is more of an individualized treatment plan for them. and it gives them a good suited feeling in recovery. Giving them little comforting hints, such as drinking warm milk. Believe it or not, it releases tryptophan and relaxes you. And it's as simple as that. They may seem very basic and homeopathic, but it's true. That inner soothing and comforting comes from the counseling that is given to them. And if they are, getting the right indicators, they grab onto recovery, and the next thing you know, they're sober, and they love it.
It's really important that there is open communication between the nursing staff, the counseling services, and the medical staff, because many times what patients are struggling with isn't just dose related, but sometimes it is. Unless we're communicating so that we know all the way around the circle what's going on, it's very difficult to manage what issues might come up.
As a grant manager, how have you used or seen the hub and spoke funds being used at your site to help your patients get effective treatment?
I have seen people that are undocumented come into the clinic, and I have gone to Clinica Medicas to voice that we have the grant. I have people that are underinsured, that don't have enough money for medication. I have people that have no medical coverage at all that I've been able to help. I know it's hard to see them when they have no insurance or no money at all. How did they become addicted to begin with? That doesn't matter. They are, and they need that help. And to have the grant, the SOAR 3, to assist them through the difficult times of getting, help, is extremely important. And then for them to use the experience that they have as a mirror to prevent them from relapsing, I think is really important too. Uninsured, undocumented are people that I've been able to help, and I'm very glad for that.
Is there anything else that either of you would like to share?
I wish that we had the ability to get the word out that methadone dosing is it's not something that's limited in terms of its effectiveness. We frequently have patients that go to the hospital because of some other problem, and they're on a dose of 220 milligrams of methadone, which then is interpreted by the treating staff at the hospital as excessive, and they try to taper them down because, oh my gosh, you're going to overdose. And it's like, or they don't medicate them with their methadone while they're there, and say, you don't need it because you're already on methadone, you don't need any pain meds. And that's just incorrect, and I wish that information was out there a little more clearly. There's been numbers of medical journal articles addressing this particular issue, but it seems to still be a problem. Like I said, there's no high or low, there's only right and wrong.
There's a stigmatism on the methadone, which it's been there for years and years. I have seen a lot of people recover with methadone. They get at a stable level and they don't want the pain anymore. It was a pain to get to that, therapeutic level. And once they get there, they're like, oh no, I remember what it was like and I'm not going back there. And they feel comfortable and they're stable and they stay clean and they give us clean tests. They get jobs. It's a tremendous turnaround. I really, really enjoy being able to help people, and that stigmatism I wish would just be indicated and changed.
Thank you both for sharing your insights with us today. Much appreciated.